So I'm delighted to introduce Neil, who already spoke today, and he's coming from Our Lady's Hospice and Care Services. He's a principal psychologist and head of psychology, and he'll be talking about the profile of psychology referrals within specialist palliative care services in Ireland. So each presenter have 4 minutes for presentation. We're quite tight of time, so good luck to all.
So, hello again. So, in essence, I'm going to talk a little bit, very quickly, about what happens when the rubber hits the road, when we put resources into developing services in terms of psychological care. What does that look like? And specifically, what does it look like over a 12-month period in an inpatient setting and a 6-month period in an outpatient community setting? And we chose this time frame to reflect a window where we actually had our full complement of staff. We were able to recruit a senior psychologist and a staff grade psychologist and an assistant psychologist. So we were able to open pathways across all the sites, the 3 different sites in Our Lady's Hospice, in Blackrock, Wicklow and Harold's Cross, across inpatients and community settings. So essentially we want to look back then, when we open these pathways, are we getting appropriate referrals? What are people getting referred for? Are the numbers of referrals increasing as we actually embed these services within the hospice? So in terms of some of the key insights, so as mentioned, once we had the resources, we were actually able to open new pathways. We were actually able to create access, equitable access for patients across inpatient settings, outpatient settings, regardless of geography, whether it was Wicklow, Blackrock, Harold's Cross area. All teams had equal access via an e-referral system. And unsurprisingly, we saw a significant increase in referrals. So we saw a 98% increase in referrals from Q1 of 2024 to Q4 in 2023. So in terms of why people were being referred, well, as part of the e-referral system, we asked people to indicate what type of difficulty do they perceive the person requiring support for the most, and what type of intervention, therefore, would be best matched to this patient. So adjustment difficulties were the most common type of psychological presentation, and this was mirrored almost identically across inpatient and community settings, followed closely by anxiety, depression, and anticipatory grief. Crucially, were the right people getting the right service at the right time? And 99% of people referred to our service were identified as having at least some degree of psychological distress, as identified by our system, the Palliative Care Outcomes Collaboration, or PCOC as we call it. So we found that approximately 87% of community-based patients were experiencing moderate to severe levels of psychological distress. And this aligns with international best practice guidelines such as the NICE guidelines that specifies not everyone needs access to specialist mental health services or supports, but a certain proportion do. Those with the highest levels of distress and most complex emotional needs do require access, and that's what we're seeing. They're the people that were getting referred. So you see the breakdown in terms of the PCOC scores, 0 being distress is rated as absent via the clinician rated score, whereas 3 represents severe emotional or psychological distress. Of the patients that were referred to our service, very, very few had existing supports. These people were really in a desert of resources in terms of their psychological health. Only 4% were actively linked in with a community mental health team. So here we have a vast profile of patients with very heightened distress, complex emotional needs, and no services prior to referral to the psychology service in the hospice. Roughly 1 in 3 of people referred in the community indicated suitability the clinician indicated suitability for telehealth, and of this one third indicated that telehealth actually was the only option that was viable. But this is good news from the point of view of it suggests that telehealth is viable, that it does increase access, particularly to people who cannot travel for appointments or who aren't currently in an inpatient setting. So it definitely opened up access to psychological supports for those who otherwise wouldn't get them. In terms of average number of clinical contacts per patient, on the whole, when we divided over the total number of people seen across inpatient and community settings, it was 3 contacts. So that mirrors data we have from the United States, and it's just slightly higher than data we have from the UK. So overall, when we build it, and they will come, as the old adage goes, the service has successfully integrated. I see a good few of my colleagues here. Hopefully they agree. I think they will agree that it has integrated quite well into the overall skill set within Our Lady's Hospice, and that the right people are getting the service. It's not that the floodgates open in terms of referrals. As a service manager, that's always your fear, that if you provide a service, you won't be able to meet the need once you identify it. But we're seeing we have a system, and particularly a need referral system, that can only get better in terms of actually getting more nuanced at assessing distress. That as we use better tools, particularly patient-rated distress tools, so asking people themselves to rate their distress, we get more accurate information on people's sense of psychological distress, and it means then we can reserve those services for those who need them most when they need them most. Thank you.
Thank you very much for that. And I think what I will take from it is it's catering for all, that people need the services as they need it, when they need it, and we need to provide a variety of different support services. So thank you very much for that. And our next presentation will be done by Dr. Razieh Safarifard. Sorry about that, I know the difficulties myself, from the Dublin City University. Razieh is a postdoctoral researcher, and she will talk about multi-stakeholder consultation to inform adaptation of digital storytelling intervention for children receiving palliative care and their families. Welcome.
Thank you. Good morning, everyone. Today I'm excited to present our work on adopting a digital storytelling memory-making intervention aimed at supporting children with life-limiting and life-threatening conditions, as well as their family across all Ireland. My focus today is in the part of this project, which is a multi-stakeholder consultation to inform the adaptation of digital storytelling intervention. And it's a crucial part for the larger project, which is led by Professor Wonnacott Lambert in DCU. As we know, pediatric palliative care faces increasing challenges both globally and here in Ireland, with growing number of the children require palliative care, and we have several critical gaps in this area now. A lack of structure of memory-making interventions or memory-making support, a significant challenge in delivering adequate emotional and social support for children and their families, and limited early bereavement supports. So our project aimed to bridge these gaps by adopting US-based digital storytelling legacy-making intervention to ensure it's culturally relevant, feasible, and acceptable within the Irish context. Given the unique sensitivity of palliative care, not all intervention translates seamlessly across culture. So to achieve this meaningful fit, we are approach to adapting this adaptation with careful and systematic planning. This process evolved essential adjustments inspired by Barristown Children Charity intervention, which is therapeutic recreation model, and a structure around the ADOPT framework, which is assessment, decision, adaptation, production, and testing. And using this methodology in field, after finalizing the essential adaptation consultation question with the Professor Moore, specialist in ADAPT methodology for our project, we organized 2 virtual consultation process consultation with the wide range group of stakeholders, people from original intervention team and Barristown Children Charity, research team members in DCU, bereavement parents as PPI contributors, and collaborators with specific memory making and palliative care in Ireland. And each consultation session included presentation, mapping similarity and differences between original intervention and Barristan intervention, and in-depth consultation, in-depth discussion based on the key adaptation questions. And we analyzed that with thematic analyses, and there are 4 key themes which was the central of adaptation process for us. First was culturally sensitive communication. For instance, stakeholders emphasizes that important of using a neutral language around terminal illnesses, avoiding words that emanate death to minimize its distress. And second is family dynamic and inclusion. We found that including entire family, like siblings and all family in storytelling process is crucial for Irish families. And the third is personal memory-making strategies to provide tailoring strategies for diverse family needs and children needs, like a specific approach for nonverbal children, and comprehensive staff training and support, as it is essential for sensitive topics like this to and staff need to be well prepared to deliver the intervention empathically and ensuring the supportive experience for all of the family involved. So we are using all of these teams and these consultation teams that we have to adapting the intervention and make sure that we are building really good memory-making intervention for all Ireland. And here is a list of our funders and collaborators who supported has been invaluable in making this project possible. We love them all equally. Thank you all. And thank you. And here is the Professional Palliative Hub. We are updating all our information there, and I will be happy to take any question of our work. Thank you.
Thank you very much for that, and so important that the tools that we're using are really culturally sensitive. Oh, the wrong way. So I'm delighted to introduce John. John is here. John is a specialist palliative care chaplain at the Northern Health and Social Care Trust, and he will be talking about spiritual training that he was delivering within her teams and how it worked. Welcome, John.
Thanks so much, Kasia, and it is a real privilege to be with yourselves here today, and it's a real privilege to do what I do as a chaplain, and the support I get in the Northern Health and Social Care Trust is amazing, as well as the support of the Institute. And I know I speak for chaplains across the island, to be part of the community of practice that the Institute organises and sponsors is a wonderful gift to us as a profession. So I want to share this morning about a collaboration I did with a local care home group and also the Northern Trust's Palliative Care Service Improvement Team. And we focused on measuring the difference that training can make in terms of the staff's confidence in delivering spiritual care to their residents and to the residents' loved ones. And interesting that training has come up so much today already. So the needs that we identified through the research was first the need for older people to have person-centered spiritual care in its broadest context, not just from a religious perspective. As we know, in healthcare, very often we're seeking to address what is the matter with the person. Spiritual care comes from a slightly different angle, and we say, what matters to you? What is it that gives you that sense of meaning and purpose? What's an anchor point in times of difficulty? And when we discover what matters to someone, then we're in a so much better place to care for them. And Leopard and others have found this. too. And secondly, then, staff, the researchers show would need help and training in delivering spiritual care, especially when they're coming from a different worldview, such as maybe a different culture. There's very often that perceived divide, at least, in terms of understanding and background, perhaps from, and I know I'm making huge generalizations here, but perhaps from a more younger workforce seeking to get alongside older residents and their loved ones. So, again, this is backed up with the likes of so what did we do with regards to the training? Well, the participants were a mixture of home managers, activity coordinators, and the leadership team, and then the varieties of methods that we use in terms of teaching. There was space for reflection, group discussion, there was videos, and there was presentations. And what did we try to cover? Well, we looked at spiritual care and spirituality being much more than religious care and belief. And I think this is one of the key penny-dropping moments with the staff, that it did not necessarily need to be from a religious perspective, and spiritual care could be that empathetic holding of somebody's hand, could be connecting with somebody through the photos in their room, could be organising the GAA shirt for the person that was rooted in that local community, in that team. And we're saying that we looked at spiritual care and spiritual assessment too. We're saying really that there can be as many spiritualities as there are fingerprints. And that makes spirituality a challenge, but also a huge opportunity. We looked at key communication skills, other spiritual care tools, and also the importance of taking good care of ourselves, especially delivering spiritual care in the context of palliative and end-of-life care. So briefly then, the results. Abby? Thank you. So we gave questionnaires before and after the training, and before, more of the folk would have been perhaps not so confident or not very confident. Some were fairly confident. And then we found after the training, the feedback was that folk generally moved to being either fairly confident, very confident, or extremely confident in a whole variety of areas, be it looking after the spiritual needs of the person, signposting to other resources, etc. And some of the feedback then from the participants in terms of in terms of what they would change in terms of practice, they said they would be more proactive with residents and families, have more discussion with staff, encourage them to feel confident in dealing with death and dying. And some of the key takeaways, understanding how to deal with people's different spirituality, feeling confident about talking about death without embarrassment. So going forward then, it would be great to roll out this pilot across the workforce. It'd be good to develop a spiritual care toolbox and more in-depth training. And you measure the effectiveness of of this through further feedback. And also even checking on maybe how many admissions there are to hospital EDs. And then this work will then feed into the palliative care and partnership review of the palliative care workforce that's coming up, and also the Northern Ireland Assembly. Thank you.
Thank you very much for that, John. As a person who worked quite a lot in the nursing homes, residential homes for a number of years, I know this is very important work, so thank you for doing that. I'm delighted to introduce our next two speakers, and that's Dr. Ashleen Crowe and Dr. Rachel McAuley. Ashleen works at Queen's University, Belfast, and Rachel is based at Dublin City University. And they are both working on the co-decide study, and they will talk about bereaved parent experiences of support during decision-making about the location of the child end-of-life care. Welcome.
Thank you for having us. So yes, my name's Ashleen Crowe. This is Dr McAuley, and this is a collaborative project between Dublin City University and Queen's. Sorry, need the mic. But Queen's University Belfast and Dublin City University, and this is the All Ireland Co-Decide study. So the aim of this study was to co-produce a decision-making framework for planning specifically the location, the place of end-of-life care for children, young people and their families on the island of Ireland. What we're going to talk about today, briefly, is specifically the interviews that we conducted with bereaved parents and looking at the locations where they chose for the death of their child. So background, parents and children require support during their palliative care journey, particularly pertaining to information provision and that emotional support whenever they are making that decision of where their child's end-of-life care should be. And we know that it's a very emotional time, and that the parents are trying their best to meet the demands of what's required of them during that really stressful and difficult stage. But in spite of that, there's not enough evidence out there about how parents and health and social care professionals can share in that decision making while trying to navigate that circumstance. So we conducted a qualitative study. There were 19 semi-structured interviews, 9 conducted in Northern Ireland and 10 in the Republic of Ireland, and we collaboratively, thematically analysed the results between myself and Rachel. And the interviews were conducted with bereaved parents whose child had died at home, hospital and hospice within 4 years of them being recruited.
So these are just some of our preliminary findings. So we found that health and social care professional support included bolstering self-efficacy and parents' caregiving abilities, advice and symptom management, practical assistance in decision-making and formal psychosocial supports, while familial support comprised of supervising well-being of parents, caring for child siblings, being present for parents in care settings, providing acts of service such as feeding family and transport, and the intuitive emotional support that comes with being a close loved one of these people. So while health and social care professionals could offer a range of psychosocial supports that familial support couldn't provide, such as social work, psychologists and situation-specific therapy, parents could also benefit from familial supports in processing and decision-making. And I think what's important is that while we would have traditionally conceptualised health and social care professional support as being the tangible kind of hard skill support and familial support as being the intangible soft kind of skill support, that fails to acknowledge that there are community nurses currently at kitchen tables around the country embracing parents and offering that informal social support. And there are family members that are providing the scaffolding of respite and providing the childcare for other siblings that is needed so that parents can attend a medical service with their child, for example. So there are more structures and there's more formality and a lack of formality in these two groups. So there is a grey area that has failed to be recognised by previous literature. So in summary, formal and informal supports are required to adequately cater for the variety of parent needs while navigating the child's end of life. Frances put it really well earlier, saying it takes a village. It really does. And it takes the range of skills provided by each familial and health and social care professionals in order to adequately cater for all these parent needs. Parents also discuss challenges in acquiring support. From health and social care professionals, these included communication breakdowns and blackouts, particularly between teams, and the timing and delivery of conversations with health and social care professionals often left parents with the sense of being abandoned, and then just lack of services and information available about services. And in terms of familial obstacles, the unavailability of family members, particularly for families that Ireland is not their country of origin, their families are all in a different place. The age of the family members, if there is only grandparents available and they're not adequately able to say, pick up children and provide care or transport or feeding families in this way. And then parent unwillingness, as so many of the presentations touched on earlier, to burden and upset other family members. So sorry, they're such high-level findings, but we should be publishing from this work in the coming months. So thank you so much. This is our whole team, and thank you to our collaborators too.
Thank you, well done. I think it's the most challenging presentations actually are when you've got 4 minutes and you've got such a huge amount of work that you've done. So well done to everyone. So that's the end of our session, and I would like to introduce now Jane. Where is Jane? There. Jane and Barry will talk about insights into spiritual care research.